so stunning was your work. And I think, you know, what we're seeing here is the future. Isn't it so nice to be part of all those abstract discussions on where we're going and the theology, ideology, and all the rest of it, and to actually see two people who are really, you know, making waves and also making enthusiasm amongst the frontline clinicians and getting them, you know, actually doing the job. It's fantastic and such a change. So is our microphone in place? Great. Who's going to ask a question?
Hi,
say who you are.
I'm a GP from Gloucestershire.
Yeah,
well done to both of you. That's really good what you've achieved. One of my questions is about communication, particularly around IT. Have you got an integrated computer system so that practices can talk to each other, social care can talk to practices? So how did you do it if you're nodding your heads in the wrong way?
You've got an hour. It's working.
Yeah, it should be. Yeah.
Certainly, with the governance side of things, just to get the data out of practices as a start, we're a multi-provider, so we've got everything from Vision EMIS, TPP, to iSoft, to Microtest. We've got the full house where we are, so we've had to use different ways of doing it, from using Apollo extracts to MyQuest queries to remote access. We've done a lot to get the data out, and we've got a mix mash to achieve that, and that's a structural thing. Moving on, we're doing some interoperability work, so we're trying to get our COPD teams linked up. That works well with things like Vision and EMIS and things like that, who are signed up to that sort of way of working. We hit a wall when we hit work with the likes of TPP, unfortunately, but I shouldn't say that publicly.
But presumably not connected to social services yet?
We are, for the COPD we are. We've finally broken that barrier in the sense that for our COPD patients, we'll be able to have a social care summary coming through, again with explicit consent at the point of care. But so we're linking up that if someone in the out of hours, in the GP service, sees someone at 10 to 6 and want to change their escalation plan, it will be immediately there real time for the Devon doctors out of hours in their Adastra system to see it 10 minutes later. And I think that's the way to move forward, is this whole real-time interoperability. But this is so complex. And you talk about sort of giving people, I mean, the governance just, every practice has its own IG lead. It's called Guardian, so you've got to get 100 odd practices to approve it. Then all the providers, different providers, and it's a minefield.
But then if you're going to do your system change, that is something you're going to have to achieve. Otherwise, you're just going to be tinkering, aren't you? Because if we all got paid in different currencies, it's just confusing. You really need to deal with one currency, and it just seems like a no-brainer if you can get everyone on the same system that talks.
Yeah, or if they don't have to be on the same system, they just have to speak the same language, and that's where the whole interoperability toolkit and the Connecting for Health is going for. That actually we have an agreed language, and everyone exchanges information in that way, and that's just going to do more, because otherwise you're having to rip and replace everyone's systems, and that's difficult. Sorry,
Joe, have you fixed that in Brighton?
I think similar challenges as to Paul. I mean, we're certainly looking at it from the actual care planning perspective and ensuring that that's as up to date as possible and circulated to those that actually need to know, and using that within the ambulance system as well provides us with the ability to do it on that sort of real-time basis, because it's very much a web-based approach. The urgent care clinical dashboard, we're developing the mechanism to actually have the care plan sitting on that dashboard as well, so that actually it doesn't matter where you are, you should have access to it and be able to see what's happening for that patient. But we originally started with actually going down the line of information sharing agreements and using secure NHS mail to actually communicate through that way for the care plans. But I mean, ultimately, it would certainly be helpful to have one system and one approach.
Well, thanks, Joe. Question over here.
Hello. Is this working? Yes?
Yes.
I'm Carrie Chill. I'm a GP in Merton, South West London. Congratulations to both of you. Excellent work. Could I just ask, are both of your systems working 24/7? And do you have any medical input other than GP?
Okay, first.
Our community teams, the integrated primary care team, is 7 days a week, 8 till 8, and then that transfers to our out-of-hours service, who pick up from a nursing perspective the urgent cases overnight, but all information in terms of the patient's needs or patient's requirements are transferred through that. From a medical perspective, mainly primary care in hours, but what we also have done through the pathway work with, for example, respiratory teams, diabetes teams, and also our sort of stroke teams, is very much ensure that it's actually come probably more hospital-based, consultant-led input there.
Yeah, sorry, very similar really. Like I said, we're trying to introduce the care of the elderly. Part of our core groups, the staff grade from the community hospitals involved, so we've got the whole seamless flow through the system as well there, so during the week, and then it's just the communications at the weekends with the out-of-hours doctors and the overnight district nursing service again, so making sure they're the same sort of teams and the communication there really. So.
Any other questions? Just one last one here, front here. Yes, if you could say who you are. Yeah.
I'm a GP from Blackburn. I'm an urgent care lead there as well, and we're facing similar challenges to what you faced, deprived population. The one main question was, how did you get people to work together? Because I think that's, especially in the integrated teams, that's a big problem that we're having, clinicians not wanting to work together. So did you incentivize that and get them to work together, or did you have to adjust the groups according to preferences?
Just to tease out your question, when you say clinicians working together, do you mean clinicians in the practices or clinicians with specialists?
Specifically in the clusters, because that's an idea we're having as well, that's how we'll need to work. But how did you, I know you've joined them together in a certain way, but would people agree to work with each other, or did you have
between the practices?
Yeah. Did you have to adjust your groups?
So how do you get GPs working together, really?
Yeah.
It's a good question.
It's something we're still working on, because you're bringing a whole range of different professional practices, cultures, experiences together. We did a range of things, certainly from the primary care perspective. In developing this service, we went back to primary care almost on a monthly basis through our locality meetings to actually help them develop this service specification, so they felt that they owned it and they really understood what it was that we were trying to do. From the community staff perspective, I think on reflection we probably could have done more, because there were certainly, going into the model, some areas of, when we talked about dispelling those myths and the understanding, but we actually ended up bringing the teams together before we went go live, and they spent a bit of time together to actually get to know each other. On incentives, we actually didn't financially incentivise them at all, other than in the development of the dashboard, which was a year prior to the teams coming into place. And the development of the dashboard was actually about backfill time for them to come out and actually look at what does that dashboard need. But we were really clear from the outset that actually this is your core day-to-day work, and actually if we get this right, this will impact on you, how you're able to sort of provide your services long-term as well, and these are your patients. So it was about actually getting to the point of saying the practice population is your caseload, so how do you as a team work together to...
And Joe, just before we finish, were there any refuseniks? Were there some people that said, well, up yours, I know what my job is and I'm not going to do that?
Maybe not in so many words, but yes, there was...
What did you do about them?
They were pretty easy to identify early on, and it's been actually almost like a broken record, and actually using the levers of different individuals, not just commissioners or managers as they would have seen me at that point, and actually bringing their peers on board. And it's been using actually the positive learning to actually say, well, why don't you give it a go? And they are coming round, and we have some who were the biggest negative people around this model who now are actually the advocates.
I suspect there was a strong element of a nurse who didn't take no for an answer, but Paul.
Yeah, I'd agree. And incentives are great in the sense that they will drive something and move it forward, but they're not without their consequences. And once you start incentivising, you get into the whole issues of what's written in the spec and people enjoying what the spec says. And in an ideal world, you try and do it without it, to be honest. And I know Sir John Alderman wanted it in part of the GP contract. Case management should be part of that, the new GP contract when it comes out. And I can imagine the more this becomes more common, that what we're doing and those sort of integrated working, and it become less need to incentivise, and at the end of the day the money's run, we've got to do something different. And I think if people want to carry on, you can stick your head in the sand, but as far as GP practices go, and I think we need to just think of the future, and managing patients like this is the only way we're going to make it, really, I think.